Shona Nag. I will shortly introduce her. Then there will be question answer session from all the participants, which Dr. Shona Nag will take. Dr. Shona Nag will then conduct a small quiz for about 20 minutes on this topic, and this will be followed by a summary of today's proceedings by Professor Pankaj Shah, and then we will have closing remarks from Dr. Manoj Kumar. So that is the program for today. Most of you are very familiar with HER2 breast cancer, but one of the problems with the treatment for HER2 cancer is that it doesn't, most of the drugs don't actually penetrate into the central nervous system. And so the whole idea of this is how to treat CNS metastasis. How do we treat CNS metastasis in a patient who is HER2 positive for breast cancer? It can occur simultaneously. It can occur at a later time, that is metachronously, when there is no disease elsewhere in the body. So Dr. Shona Nag will take you through all that. Before I hand over the podium to Dr. Shona Nag to the students, let me introduce our teacher for today. Dr. Shona Nag completed her training in medical oncology from the Tata Memorial Hospital in Mumbai and also from the St. George's Hospital in Sydney, Australia. She practices as a consultant medical oncologist in Pune, as the director of oncology for the Sahyadri group of hospitals and the Ruby Hall Breast Cancer Center, where she treats exclusively breast cancer. She is a visiting oncologist and a part of the teaching faculty at the breast clinic in the KEM hospital in Mumbai. She has been actively involved in clinical research and has been a principal investigator for over 70 global oncology trials. Most of them, incidentally, have been in breast cancer. She has numerous publications and presentations to her credit. In 2010, she was awarded the Breast Principal Investigator and Site for Clinical Research in India by the Indian Society for Clinical Research. The same year, she was also awarded the GlaxoSmithKline Ethnic Research Initiative for Breast Cancer Research in Developing Countries. In 2018, she received the Times of India Health Icon Award for her contribution to oncology from Pune. She is a member, as you know, of several international cancer societies and our own Indian Collaborative Oncology Network, as well as the Indian Society for Medical and Pediatric Oncology. She has been on several advisory boards, including drug safety and monitoring boards for drug development in this country. Her special areas of interest are, as we already know, women's cancers and cancer genetics. She is involved in cancer prevention through awareness campaigns and public health lectures. She is a managing trustee of the Nag Foundation, an NGO involved in cancer care, research and education. Apart from patient care, the NGO is involved in the survivorship aspects of breast cancers. Indeed, she actually solicits every year best proposals for doing public health related breast cancer research and ovarian cancer research through the Nag Foundation and awards for them. So over to Dr. Shona Nag to take all of us on this journey of HER2 breast cancer and its CNS disease, how to manage. Dr. Shona Nag, the floor is yours.
Thank you, Dr. Raghu. That was a very, very kind introduction. So let me see if I can get this right. Just one minute. I'm really so technically challenged. Just give me a minute. I'll just.
It will come, man. No worries.
No, I had it all downloaded. Ooh. 1 minute. Just give me 1 minute. I'll just be here.
Are you trying to share your screen?
Yes.
Share. Which one?
It's not you. That's
Where's the web pop?
I don't know.
This one? Got the first
Yeah.
one. Okay.
Excellent, ma'am. It's coming. Yes, ma'am. We can see it.
Sorry about the glitch, and I'm ready to go. So today's topic given to me was the management of CNS metastasis in HER2 positive breast cancer. I thought I would divide the topic into various headings. The introduction, touch on epidemiology, for which there is indeed a lot of data from registries, talk about local therapy for CNS metastasis, anti-HER2 therapies, various clinical scenarios where I will also demonstrate few of the cases that I have treated in the recent past, talk a little bit about the intriguing aspect of intrathecal trastuzumab, and finally, address whether CNS prevention is possible at all in this clinical setting. So, after lung cancer, we all know that metastatic breast cancer is the most common tumor to be associated with brain mets. And as women with metastatic cancer live longer, brain mets have become a very important and life-limiting problem. And there are various risk factors which have been stated. Excuse me. One has been the stage of the disease and stage of diagnosis. That is really very important. Then the breast cancer subtype. And there are a lot of other factors like a younger age, pulmonary metastasis, and African American ancestry. Although these factors are very closely related to triple negative breast cancer as well, and those may be confounding. So let's start with the stage of diagnosis. And there's lots of data, and basically the consensus is that in early breast cancer, less than 2 to 3% of patients will develop brain metastasis, whereas in metastatic disease, brain mets are diagnosed at the time of initial diagnosis almost in 10 to 16% of patients. The subtype, as I mentioned, is really very important. So as you know, almost half the patients with HER2 positive disease will develop brain mets at some point during their disease span. In triple negative, this varies between 25 and 50%. The percentage is much lower with ER positive metastatic breast cancer, but that is 10 to 15%. But we now know that the PIK3 mutant variety of ER positive breast cancer has a 30% incidence of brain metastasis. And strangely enough, patients with germline BRCA also are prone to developing CNS metastasis, 53% with BRCA1 and 50% with BRCA2. This is from recently published data. And this again could be related to the triple negative phenotype. Brain is often the first site of relapse in HER2 positive breast cancer. That's a very clinically frustrating situation which we have all faced. Let's talk about a few registries that are available. There is a large European registry, actually it's a French database, ESME, where they looked at over 22,000 patients with metastatic breast cancer collected between 2008 to 16, and they found that the percentage of brain mets at any time during metastatic disease varied. It was highest in the ER negative HER2 positive group, then came triple negative, then came ER positive, HER2 positive, and finally ER positive. And this has also been substantiated by US data. So SIST-HERS is a prospective US-based registry of newly diagnosed HER2 positive metastatic breast cancer patients from 2012 to 16. And here, of almost 1,000 patients, CNS METS was observed at initial diagnosis in 87, that is 8.9%. And in 21.7%, it developed after diagnosis. It was funny, but at that time there was a lot of data from with lapatinib. So patients at diagnosis with brain mets were more likely to receive lapatinib than trastuzumab, 23% versus 2.5%. The median PFS in this overall cohort was 9 to 10 months, and the median OS was between 30 to 38 months. Patients with CNS METS not only lived less, but they also had a poorer quality of life. Now we know that the survival has improved, especially in the HER2 positive patients who are living with brain metastases. And we have a number of prognostic classifications of patients who have received whole brain RT who are diagnosed with brain mets. And one of these is the GPA, or graded prognostic assessment. Another one is the RPA, which is the recursive partitioning analysis. And basically, you look at things like the performance status, you look at the subtype, you look at the age less than or more than 60, look at the number of brain metastases, you looked at the presence or absence of extracranial disease, and you divide the patient to high and low risk groups. And here I've just outlined for you that patients with a higher GPA score of 2.5 to 4 can have a median survival of 2 to 3 years. So the GPA is a very useful tool in the clinic as well. Although the prognosis of brain metastasis in HER2 positive patients has improved with the current very effective therapies. And remember that the best treatment for brain metastasis is also the best systemic treatment for that particular disease. The outcomes remain far from optimal. And trastuzumab, we know no doubt, has reduced recurrences in early breast cancer by half, but it's not really had that much of an impact on reducing brain metastasis. And I tell you this by providing some evidence for the same. So let's look at the HERA data. So they did a retrospective sub-study of the HERA trial, and they looked at CNS relapses in patients with HER2 positive disease who had received and who had not received adjuvant trastuzumab. And if you look at the two curves on top, which I have circled, so the blue one is the one who didn't receive trastuzumab and died with CNS relapse. And the red one that is almost parallel to that curve is 1 year of the patients who had received 1 year of trastuzumab and in spite of that died with CNS relapse. And as you can see, as the years are going by, the rate of CNS relapse is increasing. So we've nearly not solved the problem of brain metastasis, and we can't solve HER2 positive breast cancer if we ignore the CNS. We have to prevent it in the adjuvant setting, and in the metastatic setting, we not only have to prevent it, but we also have to treat it effectively. More data and more evidence comes from the Catherine trial. Now, this was a truly wonderful study which showed for the first time that risk-adapted therapy in HER2-positive breast cancer, where you selected out the completely resistant patients after neoadjuvant HER2 therapy, those that had residual disease, and then you gave them an effective drug like TDM1, you were able to reduce the IDFS events by almost half. And amongst these IDFS events, if you look at distant recurrences, although TDM1 succeeded in reducing these distant recurrences, the CNS events remain the same. And in fact, it would proportionally be a little higher because 4.3% of those who received trastuzumab continue to receive TRAST, develop CNS relapses, whereas almost 6% in the TDM1 group develop CNS relapses. So a high proportion of first events are indeed seen in the CNS, and even TDM1 has not resulted in reduction in CNS relapse. So is there any data, and there has been very provocative theories coming up, that trastuzumab itself increases brain metastasis? Is there any truth to this? So there was a Chinese meta-analysis published from Shanghai in 2011, which reported an increased incidence of brain mets associated with adjuvant TRAS, but the overall risk was low in both the TRAS and control groups of less than 2%. And my take on this is, we know that trastuzumab decreases recurrence in EBC, and we have a high rate of persistent CNS events, but this is possibly because our patients are living long enough to get brain metastasis. We know that there's a biological predilection or a kind of tropism for the HER2-positive breast cancer cell for the CNS, and we know that when there is no presence of brain metastasis, the brain becomes a relatively sanctuary site. So there are various reasons why this could be so. Now, when do you consider aggressive local treatment? And I must say that upfront local treatment is still the standard of care. You want a good performance status. You don't want a patient who is semi-comatose or has a KPS of 50. You want a decent age, although I say a fit patient is more important than an old patient. So you need to do a geriatric assessment and calculate the fitness of your patient. You want controlled primary disease, or you want the ability, if the patient untreated, to have effective systemic options, and you need controlled or absent extracranial disease. Your options are surgery, SRS, and whole brain radiotherapy. And the decision has to be made with the neurosurgeon, with the radiation onc, depends on the number of METS, size, the location, is there mass effect, are there symptoms, what is the functional status of my patient, and what is the patient preference finally. So neurosurgery has improved by leaps and bounds. It should always be discussed first with the patient, especially in the case of solitary metastasis. It is better than SRS in case of large, more than 3 centimeter lesions, and it is today greatly aided by neuronavigation tools. What about radiation? You can use it alone as SRS, as a targeted therapy, lesions less than 3 centimeters. You can use it after surgery. In fact, there is some data to show that if you radiate that operative bed, it is superior to just doing a surgery alone, or you can use it in the form of whole brain treatment. There is also very interesting data for SRS in up to 10 brain metastasis. We normally don't recommend that, but there was this non-inferiority study. Remember, 77 of these patients had lung cancer, only 11% had breast, and they divided patients into 3 groups: 1 brain met, 2 to 4 brain mets, 5 to 10 brain mets, and they found neither the mental score or the post-SRS complications were very different, although you can see the blue line, which is the 5 to 10, quite below the other 2 lines. So I think my radiation oncologist would stop at 4, and I will show you a case to illustrate this later on. So the evidence base for local therapy is best for initial, but we don't know much about using these local therapies in subsequent treatments, and you have to individualize on a case-to-case basis. There are multiple prospective randomized trials comparing upfront whole brain versus SRS in patients with 1 to 4 METS. We have equivalent OS demonstrated better neurocognitive and outcomes, but we have worse intracranial control. So that's something you need to remember. And typically, most of the series have included only 10 to 15% of breast cancer patients. There is much less robust data for repetitive rounds of SRS, and we don't have trials which are well designed for brain metastasis. And that's something I realized while looking up the different the medical literature while preparing this talk. We should have pre-specified and standard response criteria, defined imaging intervals, either every 6 weeks or 8 weeks, reporting of intracranial PFS, not just volumetric reduction of the disease. We need to inform the systemic therapy, the overall survival, extracranial outcomes, and the neurocognitive outcomes. So there is no randomized data of this versus systemic approaches. Please, while you are treating brain metastasis, don't forget about symptom control. Use the steroids for peritumoral edema, stabilize the patient. If there is a high risk for venous thromboembolism, LMWs or low molecular weight heparins are the most preferred choices. Do not unnecessarily give anticonvulsants. You know they interact with the cytochrome enzymes, and it's going to be a nightmare combining your chemotherapy or some of your oral agents or even TKIs with these agents. So only use it for those with prior seizures. So another very interesting question crops up. Can we use systemic therapy instead of radiotherapy for local control? You don't have a radiotherapy facility, but you have an excellent daycare. Your patient is not very symptomatic. The KPS is completely, it's a great performance status. And you incidentally found this single brain met. Can you afford to wait? Yes, you can afford to wait. although initial treatment is usually upfront RT, in special situations, you can consider systemic treatment, very limited asymptomatic disease, those who are keen on deferring radiotherapy or the facility is not readily available, and a patient who's not received multiple lines of treatment, a relatively treatment-naive patient. However, please remember there are no randomized trials comparing upfront radiotherapy to upfront systemic treatment. So again, you have to individualize the case. What are the appropriate systemic options? And this is something the medical oncologist will be most interested in. So you have the antibodies TDM1, you have trastuzumab deruxtecan. So these are the ADCs which have come up. But more interestingly, we're going to focus on the TKIs today. So we have tucatinib, we have neratinib, and we have lapatinib. And I'm going to choose to go backwards because lapatinib was the first one which we really used to address the issue of brain metastasis in HER2 positive breast cancer. So what is the data that we have for lapatinib? So if you use, there are a series of phase 2 studies. Remember, there is no randomized data for brain mets with lapatinib. A lot of it is retrospective from the combination with capecitabine. But if you look at pure brain metastasis, it's phase 2. As a single agent, the overall response rates are poor, only 6%. In pre-treated patients, when you add capecitabine, you can up this response rate to 20 to 38%. In the upfront setting, in a patient who has not been pre-treated, not received radiotherapy, you can get a response rate as high as 66%. And therefore, lapatinib and capecitabine has been included in the NCCN CNS tumor guidelines. What about the pooled meta-analysis of all these studies? These patients were all pre-treated with trastuzumab. The response rates varied 21% for single agent, for combination with CAPE 29%. The median PFS was for just 4 months, and the overall survival was 11.2 months for these patients. So I can't but help mention the landscape study, which was Bachelot study, which is why I think all of us got very excited, and we do tend to fall back on the lab-cape combination for those who have used it in its actual doses. It is not an easy treatment to give. It is fraught with toxicity, and your patient is already suffering with brain mets, and I find sometimes it is really difficult going with this combination in the presence of brain metastasis, which are symptomatic. So the landscape study did show used as frontline as a phase 2 in just 44 patients. We got an objective response in 29 with a more than 80% reduction volumetric change in 9 patients, that is 20%, and 50 to 80% in 46% of patients. What about neratinib? Now, neratinib, I haven't really used much. I've just used it on 2 patients where I had to import it. And again, it was difficult going. It's not an easy drug. And with capecitabine, you can get a really bad grade 3 diarrhea. Both my patients had terrible diarrhea. So we're going to focus not on the NALA study, which was the registration study, because they excluded patients with active and progressive brain metastasis. So we're going to talk of the TBCRC study, which is more relevant. And the cohort 3 used progressive disease after local therapy with neratinib and capecitabine. And as you can see here, almost all the patients had received prior CNS radiotherapy, either SRS, whole brain radiation, or both or more options. And these are the baseline characteristics. And if you look at the waterfall plots, you can see it's quite impressive responses in the lapatinib naive of 49%, with a median PFS, which was not 4 months as we saw in the landscape study, but 5.5 with a median OS of 13 months. And in lapatinib pre-treated, the response rates were lower, 33%. Again, a 3-month PFS with a median OS of 15 months, so slightly better than lapatinib. As you can see. Now, there were three trials which were like presented together, the poster at SABCS last year in a landmark analysis. And these included the NALA, the NEFRITT, and the TBCRC. And they looked at patients who had had an objective response versus no objective CNS response to the neratinib combination. And it showed an increased PFS and overall survival for patients who had a response compared to those who did not have it. So yes, it does have some activity, but you have to really learn to give this drug. What about the magic tool that we have now? So we have a great TKI, and it's called tucatinib. It is not yet available in India, but some very exciting data was presented in SABCS last year, and then again in ASCO this year. And ASCO this year had the CNS data. So it's a selective HER2 inhibitor with very, very little EGFR activity and mainly HER2 activity. And if you look at the preclinical model in rats, you can see that the survival in patients with intracranial so it crosses the blood-brain barrier, which is very important. And if you look at this data in patients with intracranial metastasis, it really looks much better than neratinib, which is in the blue line, and lapatinib, which is in the red line. And if you look at the phase 1b data in combination, so this was the study by METS and his colleagues, and they did not use any chemo backbone. They just combined tucatinib with trastuzumab in a phase 1b study, and they did get some good objective responses, as you can see in the waterfall plot. And if you look at the swimmer's plot, some of these responses were long-lasting, and patients lived as long as 2 years. Then capecitabine was added to this combination, and this was again a phase 1 data. And in those with measurable disease, you had an overall response rate. This is not just the CNS, this is overall in a small number, albeit of 61%. But in patients with active and progressing brain metastasis, they got a great signal with an overall response of 42%. Of course, the number was small, but this set the stage for the phase 3 HER2 CLIMB trial, which included capecitabine, trastuzumab, and tucatinib in patients, and made them comfortable enough to use patients with untreated brain mets, previously treated stable mets, and progressing and active brain metastasis. So I think this is one of the only trials to really address this and include this patient population. So basically, patients should have received TRAS, PERT, and TDM1 in the metastatic setting. They had previously treated stable mets, untreated brain mets, not needing immediate therapy, and previously treated progressing metastasis, not needing immediate therapy. So there were carefully chosen patients. And one thing I must point out, in the real world, this is not the situation. These patients are ECOG 0 and 1, and I suspect the patients with brain mets that we are getting in the clinic, whether heavily treated or even treatment naive, they are certainly ECOG 1, 2, and sometimes even 3. So you have to take this data with relevance to the current clinical setting. So patients were randomized to the triplet versus placebo, trastuzumab, capecitabine. This was a 2:1 randomization, and we had about 600 patients who were randomized. Looking at the key criteria, almost half had brain metastasis. Of these, 40% had untreated or treated and progressing brain metastasis. So that's important to note. If you look at the receptor status, 60% were ER positive, and half were ECOG 0, half were ECOG 1. Now, I'm not going to go into details of the primary analysis because we're more concerned with the brain metastasis and the CNS responses. So if you look, the primary endpoint was PFS by independent review, and it achieved its primary endpoint where you had a risk reduced by a hazard ratio of 0.54 and 7.8 months versus 5.6 months. This was in the first 480 patients who were put on the trial and who had an event. The overall survival was obviously included all the patients, and here the risk of death is reduced by 34%, 21.9 months versus 17.4. Let's come to the CNS data. So in the PFS in patients with brain metastasis, you can see, and this is what I find clinically most interesting and most relevant to us, is that at 1 year, 0% of patients with the doublet were without progression with brain metastasis, and 25% were free of brain metastasis or free of progression in the brain metastasis on the triplet. So that is the kind of clinical impact it had. I will go to the PFS values a little later, and I've made a kind of table for you to remember them. And let's go to the brain met data. So 291 patients had brain mets, 174 were active. Of these 174, 108 were treated but were progressing, and 66 were untreated. Of the stable brain metastasis, you had 117 patients. Now let's look at the exploratory analysis, and even though they are exploratory, I think the study has been sufficiently powered for this. So we looked at the CNS PFS, which was the time of randomization to disease progression in the brain or death. We're going to look at overall survival in the brain met patients. Then we're also going to look at the CNS PFS in all the different groups, that is the active group and the stable met group. Then we're going to look at measurable intracranial disease, which is confirmed objective responses. What is the duration of this intracranial response that these patients had? And finally, there was a subset who had isolated CNS progression, and they very sensibly continued the treatment after that. And they looked at the time from randomization to the second progression or death. Was it really increased, and was it's like continuing treatment beyond progression? Did it help? And the time from first isolated met again to the second progression or death. So again, the baseline characteristics, most of these had local therapy, 70% at whole brain or targeted, and 14 to 16% had prior surgery. So the CNS PFS benefit in patients with brain metastasis was really quite remarkable in the triplet group with tucatinib, and at 12 months, again, if you look, who were progression-free in the doublet? Nobody. But in the patients who received tucatinib, this was a whopping 40%. So the hazard ratio was 0.32. This was significant, but I think this is what we need to tell our patients in the future when we're going to offer them, or this is a nice way to explain the benefit of the triplet combination. If you look at the OS benefit, again, at 1 year, 46% were alive in the brain met group with the doublet and 70% with the triplet. So 24% more patients were alive, and the hazard ratio was 0.58. What about the CNS PFS benefit with active brain metastasis? Does this drug really work with active metastasis? Yes, it does. 0% without any with PF progression in the doublet group, and 35% without progression in the triplet group, hazard ratio 0.36, and OS benefit 41% versus 71% at 12 months with active brain metastasis. And this translates into almost a 9-month gain in overall survival. This, to me, is the most important slide in this entire presentation. This is a great take home that, yes, we can achieve OS benefit by controlling the CNS disease, and we can use effective drugs, TKIs with antibodies and capecitabine to do that. What about the overall survival? Okay, sorry. So what about the CNS PFS benefit with stable disease? Again, a benefit, 0% versus 53% progression-free with the triplet. Did not, again, translated into almost an 8-month benefit. But if you look at the OS, it was not very great. It was 15.7 versus 13.6 months, but nevertheless, 13% more was the gain at 12 months. So putting the results into context, and I've tried to kind of make a table for you guys. So these are all the patients with brain metastasis. These are the ones with active brain metastasis, and these are ones with stable brain metastasis. And we look at two things. We are looking at the progression-free survival in the CNS, and we are looking at overall survival in these patients. So in the ones with brain metastasis overall, 9.9 versus 4.2, a delta of 5, a gain of 5.7 months. In OS, there is 18 versus 12 months, a gain of 6 months. So this is overall data. Coming to the active brain metastasis, 9.5 versus 4.1 months, so a delta of 5.4, and a OS benefit, which is really remarkable, 20.7 versus 11.6, that is a delta of 9 months. Looking at stable brain metastasis, again, good progression-free survival benefit in the CNS, 13.9 versus 5.6, 8.3, and the OS not so overwhelmingly great, but nevertheless 15.7 versus 13.6, that is 3.6 months more. So, looking at the intracranial responses in the active brain metastasis, okay, and measurable lesions at baseline, if you look here, you can see nicely that in the triplet group with tucatinib, the objective response rate that was confirmed was as high as 47% versus 20% in the placebo group. The duration of response with the triplet tucatinib was 6.8 months versus 3 months in the placebo group. This is a good PFS to have. I think when I look at PFS in terms of PFS, which is a good quality, better quality of life, a time without rushing to hospital, a time without being bombarded with numerous hospitalizations and very active treatment, a good symptom-free time. So 6 months to me is a reasonable PFS to have, especially in the presence of active brain metastasis. So they then looked at this very interesting endpoint in patients who had isolated CNS progression, where they actually did give them local treatment, and they found even that was prolonged. So 15.9 months versus 9.7 months. Tucatinib does help in that situation also. And again, the median time from the first CNS progression to second progression or death is 7.6 months versus 3.1 months. So this is also good data. Now, there is a lot of debate about, does trastuzumab cross the blood-brain barrier? Does it concentrate in the CNS? Now, the size of trastuzumab is in kilodaltons, and you need a drug which is like, I think, 420 or 460 nanodaltons to be able to cross the blood-brain barrier. The concentration in the CSF is like literally systemic to CSF is 420 to 1, which is really very poor. So, you know, we have a lot of doubt, but there is some great imaging data where we have used PET tracers and we've used zirconium-labeled trastuzumab, and you've actually found that, yes, there is some penetration. So, yes, when you don't have brain metastasis, trastuzumab is not going to go anywhere into the brain. But when you have established brain metastasis, there's already a leaky blood-brain barrier existing, and there is some amount of penetration even of the larger molecules, even of the larger antibodies into the brain, although it is obviously not satisfactory. Otherwise, we would have been able to prevent CNS metastasis in a lot of our early breast cancer patients. This is more data showing you that if you label the trastuzumab versus a non-trastuzumab or non-targeted anti-HER2 targeted therapy, you will get again some penetration into the CNS. And this is some very provocative data where they showed by increasing the intravenous dose of trastuzumab, you were able to get some shrinkage of the brain metastasis. And this kind of preclinical data led to the development of the Patricia trial, where pertuzumab was used in patients who had received previous treatment for brain metastasis, and they received PERT with trastuzumab 6 mg per kg per week. So this is really a large dose, and this was only a poster that was presented last year. And what they did manage to show, although the overall response rates were very low, 11%, this is again without chemotherapy, you must remember, or continuation of ongoing treatment. So if the patient was on CAPE, I suppose CAPE was continued. But they did manage to show at 6 months that they did get a 51% clinical benefit rate. So I think this also needs to be looked into, and it's early days yet. What about TDM1? All right. So TDM1 definitely prolongs survival in mice-bearing CNS tumors. We have good preclinical data for that compared to trastuzumab. And what about any studies? So we have a lot of phase or single case reports followed by small patient series. So 10 patient series, 39 patient series, 87 patient series, telling you that there is an overall response rate between 24 and 44%. And you have a median PFS of almost 6 to 7 months. So this is slightly better than neratinib. And slightly better than lapatinib and slightly better than neratinib as well. And we know that TDM1 is a superior drug to both lapatinib and neratinib, and it improves overall survival. So it may be worth considering in patients who can't receive radiation, where you've exhausted your options. Do we have any randomized data? So we do have only retrospective data from a 3B clinical trial called Camilla, where 126 patients had measurable brain metastases. And you can see the waterfall plot, and the red line is those who had radiotherapy 30 days, more than 30 days out. The blue line shows patients which didn't get any radiotherapy, and the green one shows the ones that had radiation within 30 days. And you can see there is quite some activity, and most of the patients are stable or even responding to TDM1. So there was a more than 30% reduction in the sum of the target brain lesions in half the patients, in 50%. And these were in all cohorts. And in the 398 patients with baseline brain mets in this study, and remember, we only looked at the measurable ones, the median PFS was 5.5 months, and OS was great. It was 18.9 months, more than we've achieved with LAP and more than we've achieved with neratinib, and the PFS is almost the same. However, there is a caution. There have been case reports that if you are giving TDM1 soon after SRS or whole brain radiation, you can get a rebound cerebral edema. I had one such patient. She was young. She developed brain metastasis. She had SRS done for that, and she also had some systemic disease. So we gave her TDM1, albeit at a reduced dose. I started with a 75% dose, and she suddenly became drowsy for some reason. And then we imaged her. We found there was a rebound cerebral edema. She responded to steroids, and then I had to restart at a lower dose of 50%. And finally, after 3 cycles, worked my way up to full dose. TDM1 has also been combined with HER2 TKIs, so there is phase 1b data published, and now tucatinib with TDM1 is the new in thing, and I hope it's better than the triplet that we saw. So the HER2 Climb 2 has been launched. Neratinib has also been tested in the TBCRC cohort 4, and we are awaiting the data. The accrual is ongoing. Trastuzumab deruxtecan is also a recent flavor. It's been shown to have great benefit in very heavily pretreated patients, although there's limited data in brain metastasis. No study has evaluated its use in active or progressing disease. In the Destiny study that you're all familiar with, 112 patients, 24 had treated stable brain mets, and the median PFS was about 18 months, similar to TDM1. Isolated recurrences were uncommon in the CNS, and this is reassuring. So I'm going to just run through 3 cases before I wrap up to give some context to how we manage brain metastasis with HER2 positive disease in the clinic. And the first case is rather unfortunate. A young girl of 27 in 2017 was operated for breast cancer. She had T2N1 disease, ER/PR positive, HER2 positive, and was on adjuvant trast. After 9 months on adjuvant trast, I remember she came to the clinic. She couldn't walk. She had severe headache and vomiting, and she was swaying from side to side. And her brother and her husband accompanied her. We immediately did an MRI, which showed 2 lesions, cerebellar and 1 in the occipital region. And the largest was 2.3 centimeters. And we were really scared of tonsillar herniation. It was impending, and there was a great mass effect. We didn't have facilities for radiation then, so I transferred her to Ruby Hall, where she was supposed to be taken up, but we got the neurosurgeon in, and he said, "You can't radiate this lady. She's going to just herniate. I'll have to debulk her." She was immediately taken up for surgery, and debulking of the cerebellar lesions were done. And here you can see the surgical cavity. Here, this is the surgical cavity, and this is the huge cerebellar met. After this, she went on to receive whole brain radiotherapy, and she stabilized. Her PET scan was done after she stabilized, and it showed no evidence of extracranial disease. We chose to continue on tamoxifen and trastuzumab for 8 months. She stopped it on her own in July. She was very reluctant for further treatment. 6 months later, she presents again with severe ataxia, dysarthria, and headache, and it was really a case to be seen in the clinic for cerebellar disorders because she still speaks like this. So it was a classic cerebellar speech. The MRI again showed multiple cerebellar and occipital lesions, severe brain edema. She was not amenable to further local therapy. So we tried TDN1 after much discussion with the family. She received 2 doses. In 2 doses, she was able to get up from a sitting position. She was able to walk with support. The headache went down, and she was continued on steroids for some time. But then she went off to Bombay because of the COVID crisis and only came back 3 months later. Luckily, there was still stable disease in the CNS. The TDM1 is ongoing every 3 weeks. She's not now able to still walk with support. She still has dysarthria, but it's much better, and she can do some basic activities herself. The second case is a 30-year-old lady previously diagnosed with left breast cancer, HER2 positive, ER/PR negative, treated initially in 2017, completed TRAST maintenance in 2018. 1.5 years later, presents with headache and lower limb weakness, otherwise asymptomatic. Also has mild backache, And then MRI brain with spine screening done shows multiple bone metastasis, compression of the brainstem, and lytic lesions in L5 and the sacral ala. I don't have the MRI images, but here are the PET images, and you can see all these multiple studded brain metastases, which are florid. And you can see she's got widespread bony disease in the liver, disease in the mediastinum. So she has uncontrolled extracranial disease and symptomatic brain metastasis. Now, ideally, I would have given this sort of person after a local therapy, possibly TDM1, because she's young. We know there's a survival advantage to this drug, but really not financially affording. So after whole brain radiation, she was put on zoledronate, she was put on trastuzumab and Paclitaxel, and she had a remarkable systemic response, but unfortunately progressed after 6 months. She's currently on lapatinib and capecitabine, and 2-3 months, I think it's been about 3 months since then. The CNS meds are stable, and she seems to be doing well and is rather independent. The third and last case I'm going to talk about is a case who was treated in 2013 in Mumbai, 55 years old, again ER/PR negative, HER2 positive, completed adjuvant treatment. She came in 2017. At that time, she had presented with cough, and her PET showed a metastasis in the liver, bones, and lung. Her main symptom was a cough. There were nodes in the mediastinum. She was treated with pertuzumab and trastuzumab and docetaxel, continued maintenance with PERT and TRAST. In 2018, developed oligoprogression in the subcarinal node, nowhere else. The liver was completely stable, the bones were fine, everything else was fine. So we just gave her stereotactic body radiotherapy there. We continued TRAST, PERT, and added capecitabine. This we continued to 2020 February, when a repeat PET, as we do every 4 to 6 months for her, showed a suspicious lesion in the brain. She MRI done showed 4 lesions in the cerebellum. Her performance status was extremely good. She was an ECOG of 1. The largest was 1.5 centimeter, and she had a 1 lesion in the high frontal lobe. So I don't know if you can see, they've been outlined. Here are the cerebellar lesions. Here are the frontal lobe lesions. So that again is another cerebellar lesion. She opted for SRS given as a single fraction. The dose was 16 gray. This is the treatment planning scan. You can see it delineated quite beautifully. And as she had developed a few new lesions in the lung, she was switched to TDM1 in March 2020. Her brain is controlled. Systemically, she has responded and she remains well. So I've tried to kind of make an algorithm which will be easy for you to remember. You have a patient walking in with HER2 positive metastatic breast cancer with brain metastasis. You ask yourself the question, is this patient amenable to local therapy, or is local therapy not possible to very badly progressing extracranial disease or progressive intracranial disease? Patients have multiple treatments and further local treatment is just not possible. In that case, you would change your systemic therapy. If your patient was on TRAST, you may consider TDM1, you may consider LabCat. Neratinib, unfortunately, is not available, nor is tucatinib. If local therapy is possible, you finish off your local treatment. You obviously have to look at a scan to assess the extracranial situation. You have no extracranial disease, and it's just the brain that's creating the problem. She's currently not on any treatment. So there's really no data on what to do in this situation. Personally, what I do, I give trastuzumab monotherapy or trastbert if the patient is affording. Why do I not use lapatinib capecitabine? I prefer that drug in later lines of treatment. Like I said, I find it a difficult combination to give in full doses. I'm not able to deal with all the hand, foot, and the diarrhea in the clinic. It becomes very troublesome for these patients, and there is no proven benefit over trastbert. We don't know, and we know there is no randomized prospective data on what to do in such a situation. If the extracranial disease is stable, say my patient is on trastbert and just progresses in the brain, I treat the brain, and the rest of the body is responding to treatment, I will continue the same systemic treatment. However, if local treatment is completed and assessing the patient reveals progressing extracranial disease, you will naturally change the systemic therapy after the local therapy is over. So this is just something I came up with, which would perhaps make it easier for you to manage these patients. The last thing is about intrathecal. There's a lot of data, controversy, case reports at the most, and we know that very small amount of drug penetrates through the blood-brain barrier, and this happens many minutes after the administration. But the first treatment or first IT TRAST was used in a patient with leptomeningeal disease reported in 2001 in a 48-year-old. And have I used it? I've used it on 2 patients, but I haven't had much success. Perhaps my patients were too far gone. Remember, leptomeningeal is not a common presentation of HER2 positive breast cancer. Yes, if the patient has lobular HER2 positive breast cancer, it is a pretty common presentation with lobular. Now, so we know there are already only case reports, and these are a number of case reports that published. We have our very own Indian study, which was published by Seema Gulia and colleagues from the Tara Memorial Center, and they published on 2 patients who received it. The dose was 50 mg of intrathecal TRAST twice a week for 4 weeks, then 50 mg per week for 4 weeks, and then 150 mg every 3 weeks, given together with 50 mg of hydrocortisone. Do not give it alone. You will get some sort of edema and pain. And their patients had a PFS of at least 7 months, which I think is quite remarkable. And I think this probably warrants a randomized study. How you're going to get the numbers for randomization is going to be difficult. So maybe we should just do some data collection around India to see what the experience has been. Is CNS prevention possible? So guys with treating lung cancer have done it, and they've done it with this wonderful drug in ALK-positive non-small lung cancer called alectinib, where you know that the PFS has been improved with alectinib versus crizotinib. But more than just the PFS, you have a great overall response rate of 81% in the CNS. And if you look at the cumulative incidence of CNS progression, you can see it's going up and up and up in crizotinib, and how it has plateaued at 9.4% in adictinib, clearly showing that this drug can prevent CNS metastasis in this disease. So can we do the same for breast cancer? The data is rather disappointing. In Cleopatra, where we gained this huge survival advantage of 1.5 years, we have just increased the time to CNS METS by 3 months, which is not a great thing. And in the EGF study with lapatinib, it's an exploratory analysis, 2% better or 2% less. In cerebral, where TRAST-CAPE was compared to LAP-CAPE, again, conclusive, terminated early. Emilia study, again, although LAP-CAPE showed slightly better CNS activity, these were smaller numbers, a very small percentage, 9.4% of Emilia had stable brain metastasis, and the OS was overwhelmingly better for TDM1. In the NEFRI-TT and NALA, I've already talked about. We don't use a combination of neratinib and paclitaxel. We now have pertuzumab, TRAST, and taxane to fall back on. What does the future hold for us? We need to design better HER2-targeted therapies. We need to be able to disrupt the blood-brain barrier more effectively and modify antibodies accordingly. TKIs is perhaps the future of CNS metastasis. Immunotherapy approaches are being studied. Maybe we can find better chemo partners. For example, we can find irinotecan PET polymers, which are already in phase 3. We can find paclitaxel analogs, which have good paclitaxel-like drugs, which have good action against brain metastasis. So you have this oral taxane tesitaxel, which appears to be promising. Abema has great CNS activity. We also have PIK3 inhibitors, which can cross the blood-brain barrier. So to summarize and to conclude the lecture, although we have had some successes in HER2-positive brain metastasis with the now available anti-HER2 treatments, prevention of events remains disappointing in the CNS. We need to continue to include patients with brain metastasis in clinical trials, just as the HER2 CLIMB did, and optimize our ADCs and novel combinations, and this may provide the answer. Thank you very much for your attention, and I apologize if I've overshot my time.
Can we take the questions, Ashish?
No. Can we take the question first, or I would like to make
So
my
we can.
comment?
No, sir. We take the question.